And for our final chapter this week, we'll cover Chapter 4, Treatment Settings, and a little bit of background where mental health treatment began and where it's currently practiced today. Mental health asylums date back to 1860s, have roots in the Civil War era, that Victorian era. Also, think about things like shell shock, what we call PTSD, returning troops today. That was sort of an unknown phenomenon back then. And a lot of those issues begin arising in the Civil War era. And how do you treat them? And often those asylums are much more barbaric than what you'd think of a treatment setting from today. Moving on, in the 1950s, you got those first antipsychotic medications. I know we talked about those first-gen antipsychotics, Thorazine especially, if you were interested in anything like that. There's a lot of old advertisements from the 50s and 60s of them using Thorazine in areas that it really shouldn't be used in. In the 1960s, we have the development of Medicare and Medicaid with no funding for psychiatric care. In 1999, the Olmstead decision, deinstitutionalizing, and by this we mean we're getting away from those old mental asylums. There was a lot of shows. I believe there was an American Horror Story a lot of my students watched on asylum with an old mental asylum in it. And we've gone a long way from that modality of treatment. And 2016, the drop in state psychiatric hospitals from 322 in 1950 to 195 in 2019. And the current system really pushes an outpatient versus inpatient setting for a continuum of care. We do not want to keep these patients institutionalized. We want to keep them out living their lives as much as possible. Will there be necessary times for inpatient care? Absolutely. But the bulk of the care is provided in an outpatient setting. The bulk of coverage, as we said, is in the outpatient setting. You've got your primary care provider. Then moving on for more specialized psychiatric care providers. Then you got patient-centered comprehensive care, the coordination of care to manage all of the different treatments these patients are on. They've both got a primary care provider dealing with medical problems, maybe getting into a little bit of mood and emotional disorders. Then you got that specialized psychiatric care provider. And how do you really coordinate between the two so that everybody's on the same page? We're not making sure they're prescribing medications that could interact with each other. Also, a big push is improving access to mental health care. As we've touched on a bit this week, there's been great improvement over the years in access to mental health care. But there's still a lot of work to be done. There's still a lot of long ways to go. Getting into other areas, community mental health centers, psychiatric home care, where just like with home care for other medical conditions, they can receive that care at home. That telepsychiatry and telemedicine's really been a great thing for psychiatric care especially. Mobile health units, going into what they can do with telehealth care, telepsychiatry is amazing. When my wife was pregnant during COVID, she was doing a lot of her OB appointments right there at home. They'd send her home with monitors, and yeah, it was pretty incredible what they could do just right there from the living room. Moving on to emergency care, there's actually been a lot of progress in how we handle a mental health emergency as well. In a lot of settings, we're no longer just sending them to the normal medical emergency room with everywhere else. A lot of hospitals and areas actually have a dedicated psychiatric ER, a dedicated area to deal with these psychiatric emergencies. Here in Cleveland, our VA actually has a psychiatric ER right there next to their normal ER outpatient center, which has been a great thing for those returning veterans. Things like a mobile crisis team model, hospital-based consultant model, meaning there's no dedicated space or separate staffing. Psychiatric staff are on site and on call, ready to respond to these emergencies in the ED, where they can actually have a specialized psychiatric nurse to help handle these problems. Our first case study, Edgar. Edgar is a soldier recently returned from a war zone. He and his wife Annie first came to his primary care physician about what he described as depression. Edgar has mostly come at Annie's insistence. She is very anxious about his emotional state. Both you and Edgar's physician work at a patient-centered medical home. Edgar's physician calls on you to come to a team meeting when he begins to feel that Edgar needs more than he's qualified to provide on his own, which is a great thing. Medical care, getting them to that specialized psychiatric care is the best thing that we can do for them. Our first audience response question: What most accurately describes a patient-centered medical home? Would that be A, all levels of mental and physical care are addressed by a team that coordinates with the broader health system? B, emergency services, community and/or home-based services, and outpatient services across the lifespan are provided? C, the patient receives psychiatric services in the home? Or D, a multidisciplinary team works intensely with the patient with all agencies, hospitals, or clinics, whatever setting the patient finds themselves in? The answer there would be A. A patient-centered medical home provides access to physical health, behavioral health, supportive community social services through that multidisciplinary approach that coordinates with the broader system. It's considered patient-centered because the patient's the core member of that team and takes into account the unique needs of the whole person. And which type of prevention is Edgar's team most focused on? Would that be primary prevention, secondary prevention, or tertiary prevention? The answer here is going to be C, tertiary prevention. We're dealing with a problem after it's occurred. You're going to see these concepts come up in a lot of different courses throughout the ADM program. Primary, secondary, and tertiary prevention. Basically, primary prevention is we're dealing with a problem before it's occurred. When you see primary prevention, we're preventing a problem before it starts. Secondary prevention is going to be dealing with that situation in an emergent situation. And finally, tertiary, we're recovering from that problem. We're dealing with that. We're building back from that problem after it's already occurred. A great example of that's going to be with cardiac. You go to your provider and he places the patient on metoprolol, hopefully to prevent cardiac issues, prevent a heart attack from occurring. That would be primary prevention. Down the road, that patient still eventually has a heart attack. While they're in that active MI, while they're in the ER, that is secondary prevention. We are dealing with this crisis right now. And then once they're moved on to cardiac rehab, they're recovering from that MI. That will be tertiary. Edgar is diagnosed with major depression and post-traumatic stress disorder. At the team meeting, Edgar describes some of the struggles he's had with this disorder since returning home from the war. He agrees with his wife Annie and his team that while they will work on treating his current symptoms, they'll also collaborate on preventing its progression to a more severe level so that it doesn't become disabling or lead to suicidal ideation. And that is another area where we have made fantastic strides in the mental health community. The VA especially, when I got out of the Army in 2010, I was blown away at the services that the VA could provide. And while the VA still gets a lot of criticism, and rightfully so in some cases, they've come a long, long way from what it used to be. Think about the Vietnam veterans returning with PTSD that was nowhere near taken as seriously as it is today. You go back even further, back in World War I, they called it a thing like shell shock, but it really wasn't treated as the medical condition it truly is. And as much care as we can provide in the outpatient psychiatric setting, we should. There is a lot of benefits to this. Keeping the patient out in society, out with their families, provides the flexibility so that they can schedule appointments around an existing work schedule, maintain their own autonomy, and they can also get to unique providers that specialize in their area of needs. An area we've already touched on, that primary, secondary, and tertiary prevention. And it comes up a lot. I'm sure we'll be covering this again in MedSurg as well. Again, just that primary prevention. We're dealing with a problem before it occurs, making sure that it hopefully doesn't occur. Secondary preventions, identifying those problems, screening, and that prompt, effective treatment. We're treating that emergent issue right there. And finally, tertiary prevention, recovery, rehabilitation, treatment with a focus on preventing its progression. You're working with a patient who will be discharged from inpatient services into outpatient community services soon. What are some problems that may affect the success of treatment? And there are a lot of areas where, yes, we are maintaining treatment. They have that treatment provided, but have we dealt with a lot of the extra issues that have led to this situation? Everything from housing adequacy and stability, income, limited income. Are these patients able to have transportation to get to their outpatient provider? You'll see some patients come in a very manic state. After a few days, we've got them stabilized. We've got them back on their medications. They're clean, they're fed. And while they're here, they're perfectly ready to be discharged. But then they're going to be back next week Because have we dealt with the other issues? Do they have any support systems out there? Are they completely on their own? Are there family that'll help them along with this? Also, have we dealt with their substance abuse? I know this is another area we've touched on a bit, and that substance abuse is a serious issue among the mental health community as well, because they are, in a lot of sense, they are self-medicating themselves with illicit drug use, alcoholism, opioids. And once they get out, have we dealt with their substance abuse issues? Are they going to go right back into using and relapse? There's going to be a wide variety of inpatient care settings. You know, the psychiatric hospital I worked at, my primary unit was in dual diagnosis, where it had both that mental health crisis portion, but it was also with coinciding drug detoxification and withdrawal requirements. And when those two combine, it can make it very difficult to treat simultaneously. That hospital also had units that were only for mental health issues. We had an acute wing for the extremely manic patients that were a danger to themselves or others. We had specialized withdrawal units where these were patients only suffering from substance abuse, and their psychiatric care was much more minimal. You know, this is an unlocked unit. And then finally upstairs we had all of our pediatric units, which also had their own unique care and requirement needs. General hospitals, private hospitals are also going to have their own special units in some cases for psychiatric care. Other hospitals will try to transfer them over to a more psychiatric focused facility. And then finally, state psychiatric hospitals. There's going to be multiple routes that patient could find themselves in inpatient psychiatric care especially. First one's going to be a direct remission. You know, the patient has come in and admitted themselves, or they've been referred by their provider to the facility. The other would be emergency department or crisis services, where these patients found themselves in an emergency room. These patients had a mental health emergency. They found themselves in the ER, and they're now being either sent voluntarily or involuntarily to the psychiatric facility. You know, and we touched on a bit on that difference between voluntary and involuntary. Here in Ohio, we call it a pink slip, and that is a 72-hour psychiatric hold. Looks like Texas also has that 72-hour involuntary hold, where a doctor can write that pink slip and have them held for 3 days when they are presenting as a danger to themselves or others. And finally, the rights of the hospitalized patient. These patients, even on an involuntary hold, they still have all autonomous rights. They have the right to refuse medications. You know, these patients have an absolute right to privacy. Privacy is going to be a real high priority in mental health care. Patients' need for safety must be balanced against the patient's rights as a citizen. You know, and that can get really tough. You know, we had a patient in who had a wrist brace, but that brace had a piece of metal in it. And it was a lot of discussion of, are we able to adequately brace and protect this injury while the dangers of having that big piece of metal, which is be easily turned into a weapon on our inpatient unit. And it really took a lot of back and forth before we finally found a different brace that we could get the patient that would work while still not having that big piece of metal on the unit. And mental health facilities have written statements about the patient's rights, applicable state laws. Safety is going to be a number one top priority. Especially, that's got to be our top priority of making sure there's no hook points, making sure there is no way that that patient can harm themselves, that patient could harm others, but also maintaining their rights as a person, treating them with dignity. And it can really be difficult to keep all of this managed simultaneously. Teamwork and collaboration is a key part of mental health nursing. There's going to be a lot of different specialists, nurses, social workers, all involved in the care of this patient. And each member of the discipline are responsible for gathering data, participating in the planning meeting, and making sure that everyone's talking on the same page. And it really puts an emphasis on accurate and detailed charting as well. Treatment plan or clinical pathways are used to provide a guideline for the patient's care during the hospital stay. And much like clinical pathways, these are ways to standardize treatment. But at the same time, keep in mind there's not necessarily a one-size-fits-all for these patients as well. Each patient's going to have their own unique needs and requirements of what they need to succeed. The nurse's role is often to lead planning meetings, to keep everybody talking, keep everyone on the same page, and make sure nothing's getting missed. Nurses in the psychiatric setting are going to have a lot of different roles and responsibilities. That accurate charting we talked about, completing comprehensive data collection, includes the patient, family, other healthcare workers, developing, implementing, and evaluating those plans of care, assisting or supervising mental health care workers. You're going to have each unit would have nurses, but you would also have mental health techs that are also out there helping to keep the unit in line, gather data, get vitals, assisting or supervising mental health care workers, maintaining a safe and therapeutic environment, facilitating health promotion through teachings, monitoring behavior, affect, mood, being able to be very aware, have a rapport with your patient, and trying to identify problems early before they can begin to grow and prevent a danger down the road. Maintaining oversight of restraint and seclusion. We're going to be talking about restraint and seclusion much more within this course. So restraints especially, you have to very, very carefully. We use those as an absolute last resort when that patient is an absolute danger to themselves or others in a crisis. And those patients at all the facilities I've worked at, patients on restraints, they are on a one-to-one where a person is right there with it. You're going to have a whole protocol where we are monitoring hourly, checking the tightness of those, making sure we're not doing cutting off any circulation. Absolute safety is going to be your top priority, and we are not using restraints or seclusion unless it's absolutely necessary. My favorite term in mental health, the milieu. And when you hear milieu, think environment. That therapeutic milieu is a key part of nursing, maintaining that calming environment. At Cleveland Clinic, all nurses wear white scrubs, white top, white pants, except in the mental health units, where they are wearing a more subdued color, because that white color can be considered intimidating, put them on edge. The same thing with walls. Every single wall at the Cleveland Clinic is painted eggshell bright white. I get it, it's to impart cleanliness, but do we want our patient in a mental health crisis in a stark white room? No. And they're one of the only units in that whole health system that does not have white scrubs and white walls. Other parts of the milieus, again, we're hitting on safety. There's no hook points, nothing that they could get a rope or a bed sheet over. There is no weapons. That Laurelwood Hospital I always talk about, that building's been there since the 50s. And yeah, those kids are still finding screws to pull out of the walls, and you wouldn't believe the amount of dangers and things that they could find for self-harm. They can be very, very intuitive at finding anything that they could use. And that unit design, unit safety, and we want to both promote an environment that's calming, maintaining that therapeutic milieu, but we also want to maintain a safe environment as well. After a suicide attempt, Edgar tells the nurse, "I need my belt to keep my pants up. They keep falling down." Which response should the nurse provide? A, your belt is locked in the business office for safekeeping along with your other valuables. B, for safety reasons, hospitalized clients are not allowed to keep certain personal possessions. C, I cannot provide you a belt, but will help you get some pants with an elastic waistband. Or D, I'll ask the psychiatric technician to get you your belt. And the answer here is going to be C. You're going to see these therapeutic response questions come up a lot in ATI and NCLEX. And things to keep in mind, we never lie to the patient. We're never going to have someone give them the belt, because that is a danger. That is a weapon. That patient could use that to harm themselves or others. In this case, C, we've provided a patient with those hospital pants, which cannot hold the weight to be a danger. We've also provided them with pants that are going to stay up and maintain the patient's dignity as well. And specialty treatment settings. I know we've talked about that the VA and all the care that they do, specializing in veterans and PTSD. Other one's going to be pediatric psychiatric care, geriatric psychiatric care, which is a extremely difficult specialty to work in. You really got to think about the amount of people who have been living with mental health problems their entire life, but as they get older, as that dementia starts setting in, these mental health problems then begin occurring much more frequently. The things like forensic psychiatric care, alcohol and drug use disorders, and self-help options, every resource we can provide to them in the community. And wrapping up, our case study, Edgar. After release from the hospital, Edgar returns to his outpatient team. He expresses a desire to start again while acknowledging that major depression is a chronic disorder. He and his wife Annie have decided to join a support group for veterans and their families that focus on dealing with PTSD and major depression. Annie shares that he has also given her a birthday surprise. He has enrolled them both in a yoga class together, something she says that I have always wanted us to do together. They are made guardedly optimistic about the future. And the patient's acknowledging that he has a problem. He's seeking treatment. He has that support system out there, in this case, his wife Annie, to help support him, encourage him to maintain treatment. Yeah. Anyway, again, if you have any questions on anything we covered today, shoot me an email, shoot me a text, let me know. I'm happy to break down anything else you'd like. I'm also going to be putting out a poll. We'll put out, I'm open to any tutoring if any would like any additional help with anything. Again, let me know anything you need, and I'll see you next week.